All right, good morning. This is a joint meeting between Senate Health and Welfare and House Healthcare. And this morning, we're going to be meeting with a number of folks regarding healthcare system improvements that have been going on now since 2022, and looking forward to the testimony that we have. Before we begin, we're going to have members of both committees introduce themselves, and then I'll give a little speech. No, direct us toward what we're hearing about today, and then we'll move into testimony. Start over here.
Senator Larry Hart from Orange County.
Representative Alan DeMar, represent Enosburg and Montgomery.
Representative Woodland Page from Newport.
Representative Daisy Rebecca from Winooski.
Representative Chopper McFawn from Barrytown and part of Williamstown.
Representative Alyssa Black, and I represent Northern Essex. And I chair House Healthcare.
Ginny Lyons, representing Chittenden Southeast, and I chair Senate Health and Welfare.
Senator Martine LaRocque-Ulick. I am Vice Chair of Health and Welfare, and I represent Chittenden Central.
I'm Sam Douglas. I live in North Troy. I represent the Orleans County Senate District.
Debbie Powers, I live in Waterford, represent Waterford, Barnet, and Reiki.
Leslie Goldman from Wyndham 3, Rockingham, Westminster, and Brooklyn, the Bells Falls area.
Representative Wanda Pritchell, and I represent Colchester.
And Representative Roy Hogan.
So thank you all for being here. As we've begun to look at moving forward on system improvement, our healthcare system improvement, it occurred to both Representative Black and myself that we should take this time and opportunity to listen to what has happened and what is going on. Obviously, with the passage of Act 167, we put in place some really important work, and the result of that work is ongoing. One of the things, of course, that we've heard about is the need to maintain financial sustainability of our hospitals, but at the same time to be inclusive in looking at healthcare into community services, community-based services. So part of the work that has happened relates to the financial sustainability. And as you know, one of the reports that came out from the Green Mountain Care Board contractor, Oliver Wyman, was a little bit earth-shaking for many people, and the concern about the loss of hospitals. So what our goal has been since that time is to ensure that we don't lose the services that people need within their local areas, but at the same time, that we see each of the hospitals and each of those local areas as a continuum of care across the state, so systemic. Today is our opportunity to hear about what is happening. And as you know, the next step in history was Act 51, where we asked the Agency of Human Services, in addition to its work on hospital transformation, and hospital transformation is a big part of what AHS continues to do as a result of 167. But in addition to that, Act 51, which asked the agency to work with 4 hospitals independently and to look at what transformation needs to happen in order to save the healthcare resources that we have in those regions and areas of our state. There are other things that have happened in the meantime, and we won't go into some of those things that have really represented the cost of care that folks and the cost of insurance premiums that folks are so concerned about. So with a thought in mind that today is an opportunity for us to listen to what is happening, both at the Green Mountain Care Board, through Agency of Human Services, Department of Financial Regulation, and the work that our hospitals are doing independently. We're going to just dive into testimony, and as we go forward, we'll see what we can do. It's a little bit scary to us sitting at this table to know that we can lose the services that Vermonters rely on. So we take it very seriously. And we're looking forward to hearing about the actions that are going on to both save the system, but also to better integrate services that we have across the state. So I'm going to leave it at that and turn to Jessica Holmes from the Green Mountain Care Board. Thank you for being here. Before I do that, Representative Black, did you want to add any comments?
No, I think that was a wonderful introduction. Just looking forward to receiving updates from everyone and how are things going?
There we are.
Thank you. Thank you for the introduction. And I will just open with, I share your concern. I'm equally scared. I don't sleep well at night. So, yes. So good morning to everybody. And thank you for the invitation to speak with you today about our healthcare system. For the record, my name is Jessica Holmes, and I'm one of the 5 Green Mountain Care Board members. I think my role a bit is to provide a little bit of historical perspective on the efforts that we've undertaken, the state has undertaken to try and improve the sustainability of the healthcare system and the affordability of our healthcare delivery system. So I'm going to share some history. I'm going to share some brief thoughts on the current crisis, and I'm going to reemphasize the need for urgent transformation, which I know you've heard me speak about before. I'm here to say it again. And then I know we're hearing from AHS about the work that they're doing, and I know we're hearing from hospitals about the work that they're doing. So that is my goal. So this is a timeline that I want to share. Yeah, there we go. We've said it, our healthcare system is in crisis. You heard it from me back in January. You heard it from Chair Foster on numerous occasions. I think you've heard it from the payers. I think you've heard it from providers. I think you've heard it from the healthcare advocate. So the goal for me today is to sort of set some historical context and level set where we've been and the need to really move forward here. So the Green Mountain Care Board has been sounding alarms for years. If we go back to 2019, we convened a rural health services task force to look at some of these issues. We mandated that 6 of the hospitals develop hospital sustainability plans. I will say there was pushback on the request or the mandate to do those hospital sustainability plans. In 2020, we extended that mandate to include all 14 hospitals. Again, there was pushback. Then COVID hit. We decided to take the sustainability work in-house. We hired some consultants to help us look at system efficiencies and options for transformation. Act 159 provided us with the framework and the timeline to do that. We hired 2 different consultants to look at hospital costs, hospital prices, efficiencies, delivery system redesign opportunities. These consultant reports are on our website. Burns HMA and the Berkeley Research Group were the consultants that we hired. And then in 2021, we used that HMA analysis and the Berkeley Research Group analysis as a foundation, and we produced a report, final Act 159 report. That report made very, very clear back then in 2021 that the system was not sustainable. There were inefficiencies in the system. There were opportunities to reduce avoidable utilization, low volume, high cost care that was being delivered that was contributing to our affordability crisis. Basically, big recommendations that hospitals needed to change. The Berkeley Research Group consulting team recommended that back then that we create centers of excellence for specialized services like orthopedics to try and improve efficiencies and improve quality. They also made some suggestions relative to certain hospitals closing their inpatient units, moving that care, looking at rural emergency hospital designations. Again, those reports were, there was pushback about those reports, questioning of the data, largely clinging to the status quo. Not much has changed, some has changed, but not much has changed. The fragility of the delivery system didn't change. The heavy reliance on commercial rate to plug revenue gaps didn't change, and the affordability crisis did not change. In fact, all of those got worse. And so we are in a place, and so 2022 came around. Thank goodness the legislature passed 167. I thank you again for that. It provided us with the funding to do a comprehensive community engaged process that would include hospitals. It would include hospital boards, and it would include communities to try and understand this sustainability and this affordability crisis that we're facing and look for solutions. The goal was then to share some of the harsh realities, to share the dire financial forecasts, and to engage in collective solution seeking. So we hired Oliver Wyman to do that work. It spans 23, 24. I think you're all familiar with that report. I think you're familiar with the backlash to that report. It again offered recommendations that included repurposing some inpatient beds, creations of centers of excellence, thinking about different designations, shared service opportunities, reductions in hospital administrative overhead. That was, the work of 23 and 24. Act 51 was also passed, tasking AHS with leading the hospital transformation process. We're in 2025. We're in system transformation. We are in desperate, desperate need for this work to actually happen. I want to make clear that crisis is acute. We've been raising alarms for 6 years. We need to find ways to mitigate this crisis. And if you sense any note of frustration in my voice, it is there. I have been frustrated. I continue to be frustrated. The next few slides that I pulled together, I think will get everybody frustrated, hopefully, that we need to change. And we've been asking for this and thinking about this for years. So this was 2018. This is a collage of news articles from 2018. If they look familiar, they should, because we're in the same situation. More than half of the hospitals were in the red. Hospitals were requesting steep rate increases to cover their costs. And we required sustainability plans to try and course correct. 2019, Springfield filed bankruptcy and also was given a bailout from the state. That was 2018, 2019. 2020, COVID hit. Hospitals were hit hard. They had losses. They were rightfully so managing an emergency, a pandemic, a public health emergency. Losses started accelerating. Federal funding mitigated some of that financial hardship, but we came out the other side and the system was still in crisis. The red box was 2021. That was when the Green Mountain Care Board's first set of delivery system kind of recommendations that came out of the Berkeley Research Group's report were delivered. Again, it was meant to start a much needed conversation that we needed to have with hospitals, hospital boards, and communities. Again, I mentioned it was met with resistance, a foreshadowing in many ways of, I think, things to come. 2022, hospitals cited large operating losses and ever increasing costs and requested unprecedented rate increases for 2023. 2024, Oliver Wyman concluded the 167 statewide community engagement process. The team made some, as you mentioned, Senator Lyons, chilling predictions about the financial vulnerability of our hospital system. They recommended major systematic change, and they gave us a pretty short runway to actually implement this. Again, met with resistance by hospitals. Not a lot of appetite for change, status quo bias, continuing the affordability crisis. That's the reality. And budget cuts that the Green Mountain Care Board made to the health network were met with essential service line cuts to vulnerable communities, primary care, dialysis, mental health, all while healthcare costs are continuing to soar. Here we are, 2025. Some might say that the only thing Oliver Wyman got wrong was the length of our runway. It is much shorter than even Oliver Wyman predicted. So I will just say, I think the house is on fire and the feds are about to pour gasoline on it. Said this before, I'm saying it again. We are in real trouble. And if we do not get everybody around the table together to find significant cost savings and ways to ensure the preservation of essential services in all of our communities, patients are going to suffer. And it really, literally keeps me up at night. This is a snapshot of part of the burning house. Okay, this is our hospital operating margins historically from 2019 to 2025, Q1 of 2025. So you can see where we are historically. Red and orange, not good. Again, fire, right? A healthy margin is 2 to 3%. 2 hospitals achieved that in 2024. And the first quarter of 2025 continues to show that warning signs for over half of the hospitals. With Medicaid cuts coming our way, with potential for the QHP subsidies to be sunset, the picture looks grim. AHS can give you some more detail there. But I think as we all digest this slide, and this is really tough to hear, and I recognize that, but I think Vermonters cannot afford the healthcare system that we currently have. The costs of running a hospital are high. And with some areas experiencing population declines, we have fewer and fewer people able to cover the fixed costs of their local hospital. The cost of equipment, the cost of new technology, the cost of drugs are skyrocketing, and so are workforce costs. If your community needs one specialist, they have to hire three because doctors are no longer willing to be on call every night. They want to be on call every 3 nights. So that means you got to hire three. That is a very expensive way to deliver healthcare, and it becomes more expensive as our population shrinks. Hospitals with a daily census of 10 to 12 patients are unable to cover the fixed costs, and they don't benefit from economies of scale, and they're struggling to meet the costs of delivering care in their communities. Many of them are not achieving cost coverage from Medicare. They're not achieving cost coverage from Medicaid. And those with private insurance or those who self-pay are paying really high prices, as you've seen, and I know Chair Foster has testified and others, to keep our hospitals operating. That strategy is not viable. It's not viable. Vermonters cannot continue to pay these really high hospital prices that translate into high insurance premiums anymore. And the commercial population is shrinking, which means there's fewer and fewer of these commercially insured people to cover the costs of our system. We can't afford the system we have. What we want and what we can pay for are not in alignment. This was the slide from the Oliver Wyman report. This was the slide that terrified everybody. This was the slide that was done before the federal transition, before Trump was elected, before there were cuts to Medicaid, before there was talk of sunsetting the QHP subsidies. So this slide was done before all of that. So without a substantial increase in hospital prices, which we can't afford, that will translate into a substantial increase in insurance premiums, which we also cannot afford, or taxpayer-funded bailouts, which we also can't afford, we're going to see service line disruptions and we're going to see hospital closures. And that is the reality. 650,000 people cannot afford to support the 14 hospitals doing exactly what they're doing now, the current portfolio of services. So the same forces that are creating an education funding crisis are also creating a healthcare funding crisis. Same problems, same demographics. I would say similar need for urgent and substantial transformation. I would also say the stakes are probably higher, right? These are people's lives at stake if we don't do this and we don't do this right. This slide you've seen before. This is the insurance prices that we face, right? We pay some of the highest prices for health insurance in the country. Our insurance premiums are rising faster than the rest of the country, despite high prices, despite high premiums, both our providers, as you saw through our hospitals, also our FQHC, that didn't put a slide in there, but they're also struggling financially, and our insurers are in the red. So something needs to change. This is Blue Cross Blue Shields. This is their RBC, their total surplus. This is a measure of the money that they have to be able to pay the claims. This illustrates the dire circumstances that Blue Cross Blue Shield is in. This is the only insurer that's domiciled in Vermont. They are facing a huge financial crisis. They are running on fumes. Reserves are being depleted at frightening rates. And my understanding is that the claims surge is not waning. So we are expecting, and I think Chair Foster testified recently about this, insurance rate requests between 15, 20, potentially over 20%. If the subsidies go away, we could be looking at QHP insurance premiums, 25, 30% increases. That is not affordable. That is not possible. Rate increases of that magnitude on top of already sky-high monthly premiums will wreak havoc on our small businesses, our individuals, our families, and the taxpayers who are funding teachers and state employees. People will leave the state. And who's going to leave the state? Healthy young people will leave the state. Entrepreneurs looking to start new businesses will leave the state, right? Exactly the opposite of what we need right now. So 20% insurance premium increases are not the way to attract the people that we need to, keep our economy flowing. If the Green Mountain Care Board doesn't give the premium increases that the insurance carriers expect that they need to cover the healthcare costs, they will bail out of the market. They do not have to participate in the QHP market. So if we do not give them the premium increases that they request that their actuaries and our actuaries say are reasonable, given the expected medical costs, they'll leave. They don't have to participate, right? So the QHP market will collapse. Tens of thousands of people will lose health insurance. So my understanding is that if we cannot remove $200 million out of the healthcare system in the very near term, we will be looking at these 20% or more rate increases. If we can remove that $200 million out of the healthcare system, we can get closer to a premium rate increases of 5%, which are still high on top of, high costs of premiums. But care transformation is going to be critical to that process, and it needs to happen now. It needs to happen now. Hospitals need to find ways to wring administrative waste out of the system and find ways to gain efficiencies. We need to do this. This is just a slide. You may have seen this before. This is contributing to the problem. We have a declining commercial population between 2012 and 2021. It fell. It is going to shrink even further if premiums rise by 20% or more, or if QHP subsidies disappear, and probably, right? The 14 hospital system has essentially been financed by the high prices paid by the commercially insured population and their employers. They cannot afford to do so any longer. So again, I said I was going to say this, I'm going to say it again. We need system transformation now. Communities are at great risk of losing essential services, right? Hospitals with AHS leadership and Green Mountain Care Board collaboration must execute on Act 167 options to protect communities from the loss of essential services, critical, life-saving, and preventative services. Hospitals' financial health is poor, continuing to deteriorate. Something needs to change there. We cannot rely on commercial prices to do this. To sustain the system, it's no longer viable. It never was viable. It's not sustainable. We can't afford it. And I will also say, and I haven't talked about it here, I've talked about it in prior testimonies, but we have a serious access crisis in this state as well, and quality has been deteriorating. So those need to be addressed as well. But the immediate concern is the affordability and the sustainability of essential services. This, I don't know if you can push us ahead to the Berkeley Research Group. I just want to give a brief summary. This was a summary of the recommendations that were made by the Berkeley Research Group back in 2021. Right? There were recommendations about downsizing, service line changes at several struggling hospitals, creations of centers of excellence, looking at new federal designations like freestanding emergency rooms and rural emergency hospitals, finding ways to reduce low-value care and preventable admissions that are adding costs to the system. Right? Many of these align or are similar to the recommendations that were made by Oliver Wyman back in September. So Oliver Wyman called for repurposing of some inpatient units, creations of centers of excellence, reduction in hospital administrative costs, looking for shared service agreements between hospitals, looking at new designations for hospitals. Okay? Outlined some areas where we could have centers of excellence. Look for cost reduction opportunities across hospitals, looking for ways to share services and private, pursuing group purchasing agreements and centralizing services and sharing staffing and really finding creative ways to ensure that we can deliver essential services in every community more efficiently, more cost effectively. Going to have to be done collaboratively using regional planning. They estimated that system transformation could save $400 million over a period of 5 years. We don't have 5 years anymore. We need to find $200 million now. Okay, but these were efforts at the time of this report back in September that we could save $400 million out of the system. So this is my final slide. I know it's been an uplifting presentation so far, but to me, the system transformation, we have been trying to do this since 2019, really since 2018, which is when we first imposed hospital sustainability planning in our budget orders. We need to do this. It would provide a lifeline to protect Vermonters from the loss of essential services, right? The goal of Act 167 was to create an intentionally designed blueprint for the healthcare system we want, a system we can afford, and one that meets the criteria of Act 167. We need an efficient, affordable, high quality, and accessible system, one that meets the current needs of the population and also the future needs. And it has to be financially sustainable and affordable. So I hope we can all agree that the system's in crisis, that inaction is an action. The federal headwinds that my colleagues from AHS will be talking about, even with intentional design, I think we're going to have to expect that some services are going to have to be moved from certain communities. We want to preserve essential services. Other services may have to move. We're going to need hospitals and hospitals boards to work with the state to find ways to wring out inefficiencies, reduce unnecessary care, leverage economies of scale through shared services, and move services to centers of excellence to improve quality and lower costs. We need to ensure access to transportation. Patients are going to need to be able to get to these services. We need to really double down on transportation, and we need to ensure that telemedicine is an option, because some of these services may have to be delivered through telemedicine, and we need to make sure that patients have that kind of access. That's the kind of backstop that we need to be preparing for now. Transportation, telemedicine, and clinical transformation of our system. And we need to find $200 million in the immediate short run in system-wide savings so that we can bring down the expected insurance premium increases to a reasonable and affordable level so we do not lose people from the state, healthy people and entrepreneurs. That's the only thing we can do. We need all hands on deck. We may need some more legislative authorities to be able to do that. It's the work that, AHS is leading. It's the work that the Green Mountain Care Board is doing. And I know you're going to hear from the hospitals about what they're doing. That is the end of my very uplifting, and I'm sorry to say, scary presentation, but it does keep me up at night. Everything I've said here, I truly believe needs to happen, and I am genuinely worried for Vermonters if we don't do it right.
Thank you. So as what we'll do is I thank you for setting the table for this. It's really critically important. And I know that you've done this for us other times, and it continues to reinforce what we need to do and hear. The collaborative relationship that we have, all of us in this room have established is in much part due to the work that the board, AHS and others are doing, the hospitals and others are doing. So we cannot lose sight of the need for continually working together on this. And so thank you for your testimony. I think what we are going to do as our committees work together, we're going to listen today. At the end of the time, we will have some questions, some general questions, because we don't have a lot of time today, but this, I thank you for that. Appreciate it very much. And
Thank you very much.
we are, this isn't the last time that we'll be hearing from you. So we appreciate it. And so we'll thank you, Tom Frank, for being here from North Country Hospital. Yeah, this is the unfortunate part for all of us, and I know that when we hear from Brendan Krause in the cleanup position, we're going to feel the same way. So it's difficult. I think each one of us could probably write a thesis about what we know and what we don't know. And the importance of a meeting like this is to all get on the same page, understand where we are, and your work is critical to our understanding how we can improve the system of care. Thanks for being here.
Thank you very much. So I am Tom Frank, and I am the CEO of North Country Hospital. I am here to talk specifically about North Country Hospital, but obviously I would more than happy to take system questions, as I have worked at Fletcher Allen, I have worked at Rutland, and I've also worked at Planned Parenthood of Northern New England. So I have quite a bit of experience throughout healthcare in the state. So I'd like to kick it off with the first slide if I could. Talking about where North Country is located. I think everyone in the room realizes that we are the most rural, the remote, we are an outpost in the Northeast Kingdom of Vermont. You can see here that we are 45 minutes to the closest hospital, and that's on a good day, unless you have to cross Sheffield Heights in the middle of winter, 1,856 feet, highest point on Interstate 91. In the wintertime, you cannot get to St. J in 45 minutes, I'll assure you of that. 2 hours to Dartmouth, 2 hours to UVM. Winter, not so much. Today, yes, it's a beautiful 2-hour ride. So that's very important to consider where we're located. We are the definition of a critical access hospital. That's exactly what we do. We serve a population of 30,000 plus people in the Northeast Kingdom of Vermont. Next slide, please. So the Northeast Kingdom of Vermont, it's 2,000 square miles. That's 21% of the entire landmass in the state of Vermont. And right now, there are basically 2 hospitals in that area, covering that area. Now, as I said, we're both in the Northeast Kingdom, but St. Jay is 45 miles from where we are in Newport. As I said, we're a critical access hospital. We are the ruralest hospital in the state. Vermont is the second oldest state in the country, as you all know. We're the oldest county in Orleans County. Unfortunately, we have the lowest health status folks in the state. We have a very elderly and sickly population. And we are the most economically challenged, again, unfortunately, in the state of Vermont. My understanding is the unemployment rate in the state of Vermont right now is 2.6%. In the Northeast Kingdom, it's 5.7%. That's just a little taste of what goes on in the Northeast Kingdom. It's a completely different world. For someone who has lived in both worlds, I've lived in Essex for 23 years, and I maintain and have lived now in Glover in a family home that we've had since 1971. And I can assure you the differences between living in Essex and living in Glover are night and day for a lot of reasons, including healthcare access. And it's important that folks who don't live in the kingdom understand the difference. So currently at our facility, we employ 30 physicians. We have emergency department, general surgery. We have 2 general surgeons and a locum surgeon. We have a very robust OBGYN program. Cardiology, we've made the decision to employ cardiology. Now, what's happened around the state in the last few years, which has happened to North Country, is historically cardiology was a service that we were able to contract with through Dartmouth. For 20 plus years, we contracted a 2-day-a-week cardiologist from Dartmouth. They pulled the plug, couldn't do it anymore. So we had to employ our own cardiologist. Now, a cardiologist is very expensive, but North Country Hospital is a primary care-based hospital that does some specialty services. That's our focus, taking care of the community through primary care. And we consider cardiology an extension of primary care. Hospitalist program. Obviously, we need a hospitalist program. We have a hospital, and you'll see that we do 1,600 discharges a year. As a critical access hospital, our capacity is 25 beds. That's all we're allowed to have. This past winter, we had many times we were on diversion because we were so full. NVRH, our sister hospital, was able to help us in that case by taking our patients. But if we have more than 25 patients in hospital, we can be penalized by Medicare. So we have to be very aware of that. Anesthesia for general surgery, obviously OBGYN and orthopedics. We have ENT. We have a very, very, very small amount of ENT. He's basically 2 days a month. That's what we have for ENT services. Radiology, we just lost our full-time radiologist. He's retiring. So now we're having to contract with an outside organization who will be able to place a radiologist at our hospital part-time, no longer full-time. So we'll have to use telemedicine for that service. Primary care. So as I said, North Country Hospital is a primary care-based hospital. That's what we focus on. We are basically the only primary care in Orleans County. 95% of primary care is employed by North Country Hospital. There's a small concierge practice that has about 200 patients, and there's one private primary care physician, and I'm not exactly sure that volume, but right now we're receiving 15 to 20 new packets a month for patients that need to be seen at North Country. It's not even so much our inability to recruit physicians, it's space. We have 2 clinics. We have one in Newport, very, very newer clinic, very nice. And we have a clinic in Barton. Barton obviously is a community that struggles in a lot of different ways. We're running out of space for primary care. That's our biggest worry right now in Newport. Pediatrics, again, we have a very robust pediatric group. We work very, very closely with the University of Vermont Medical Center. We have 3 pediatricians and 2 NPs, and they are full. Orthopedics. So we made the decision to eliminate our hip and knee joint replacement service because we do believe that that's a service that can be provided elsewhere in the state. So we went from 2 orthopedic surgeons and we have 1. One orthopedic surgeon is absolutely necessary. When we made that decision, our hope was that our sister hospitals around the state would be able to help so that we would be able to transfer these patients when need be. Just one quick story. Recently, and this happens on a regular basis, we had a patient come in with a severely fractured leg. We didn't have our orthopedic surgeon on call. This was actually a situation where a critical access hospital should probably have transferred and did transfer to an academic medical center. Unfortunately, the local hospitals are orthopedic hubs, refuse to take the patient. UVM didn't have a bed. Dartmouth didn't have a bed. So our only option would have been to transfer that patient to Albany, New York. Do you know how far Albany is from North Country Hospital? So as the patient's right, this individual had no insurance, they didn't have Medicaid, they refused to apply for Medicaid. Is their right, as they sit in our emergency room, they can request to be transferred, and we have to live by that request. So we have limited EMS. We know transportation is an issue. So our EMS folks, and this is not a knock against our EMS folks because they're struggling financially as we all are. In order for them to transfer that patient to Albany, we had to write a check for $7,500. And this happens on a regular basis. As I said, we're an outpost. And in order for us to get our patients in locations, sometimes it requires us to write the check. Now we have DART, we have the helicopter service, but knowing that DART does not fly 40% of the time. So 4 out of 10 days, they can't fly. Weather, other situations where they need to be. So at times, we need to take care of sicker patients for longer periods of time. Next slide, please. So this is what we did in FY24, and this is who we are. So we have 630 employees in the Northeast Kingdom. Our total labor expense is about $69 million a year. Our estimated financial benefit to our community right now is $61 million. And I just described to you how economically challenged we are, let's say, in the Northeast Kingdom. We're a $105 million critical access hospital. For a critical access hospital, if you look around the nation, that's actually a pretty large critical access hospital. Last year, we had 16,000 emergency department visits. We had 1,600 discharges. We had 190 births. We averaged between 190 and 220 births a year. We did 230,000 lab tests, 32,000 imaging studies, 36,000 primary care visits. As I said, we are primary care. We have a major issue with electronic medical record, which I'll talk about in future slides. And as of 2024, we did have 201 days of cash. That's now down to 173 days. We've spent some of that cash down. We paid off a $5 million equity line, which was costing us $360,000 a year in interest. Also, the stock market has taken a hit. You probably didn't know that. Next slide, please. So Act 167 recommendations. Right from the very beginning, North Country has bought into some of these recommendations, 110%. And some of the ones that we're really focused on, which we feel are the ones that are absolutely essential and make sense for North Country, are investing in primary care. We've been able to recruit 3 new primary care physicians in the last year, 2 new primary care APPs, that's a nurse practitioner or a physician assistant, 1 new pediatric physician, and 1 new pediatric NP. This is our focus. This is where our action is. Next slide, yes, please. So what have we done? So one of the other big things, and we recognize this, and we're all about this, we can't do this alone. We have to collaborate with other hospitals. And so Sean Tester, the CEO at NVRH, and myself have begun to work on what it would look like to create a Northeast Kingdom health system, a system where we can have shared services, a system where we can recruit together, a system that makes sense for the Northeast Kingdom because we are that much farther away from everyone else. So we formed a limited liability corporation, LLC, several years ago. And together we built a sleep center in St. Johnsbury. And that sleep center is split 60-40. 60% of expense and revenue come to North Country, 40% to NVRH. They're employees of North Country Hospital, but we share the expense and we share the revenue. We brought our boards together to have this discussion. Our boards are very much in favor of working together as a community to create this healthcare environment for the Northeast Kingdom. Senior leaders are in touch regularly. I don't like to use the word steal, but we steal policies from each other. We steal resources from each other. We collaborate. Who has an expert in a particular area? They'll come to our hospital. We'll go to their hospital. We'll do education sessions. Continue. Next slide, please. We brought our senior leaders together to work on structure, to work on implementing different things. And so we have our second meeting coming up in June. We have regular meetings between Sean and I to talk about what services we'd like to recruit together, but the recruiting of services right now is on hold. We've met with AHS. We've asked AHS for assistance to do various analysis. We don't have a lot of resources in our organizations to be able to do that. We're going to be working with the Rural Health Redesign Center. We've supplied them our data, and we have our first meeting with them on May 7th. North Country has always been willing to try whatever we can do to do what's best for healthcare in the state of Vermont. We've been in the ACO. We've tried everything under the sun. We do whatever we can because we recognize the expense of healthcare, and we also recognize how important our hospital is to our community. Next slide, please. So I'd like to, Jessica brought this up, which I think is really important. I'd like to bring up our income statement real quick. And you can see that historically, North Country has been able to sustain ourselves without asking for dramatic fee increases. But as you can see in fiscal year 22, things dropped off the cliff. And what happened there was we implemented a new electronic medical record, and I'm not going to lie, it's been a disaster. A disaster that you can't imagine. You can see here that we lost $9.3 million in 22. Our EBITDA, which is earnings before interest, depreciation, and amortization. To me, that's the true test of the financial strength of a hospital. Was a loss of $5.8 million. In 23, we lost $8.7 million. I came back to the hospital 2 years ago. I was at Rutland. I came back after being COO at North Country to become CEO. And the goal was to turn this hospital around financially, culturally, and remove this EMR and move on to something new. So the first year, we were able to reduce our loss from 8.7 to 2.6. And currently this year, through the first 6 months, we actually have a slight profit of $3,000. And we anticipate that getting better. Now, in that loss of $3,000, you're going to see I've highlighted a legal expense of $1,039,000 that's going to increase dramatically for the rest of this year. We are in a legal situation with aspects of our EMR system based on our $18 million loss in the last 2 years. And even with that additional unbudgeted $1 million expense, we still have a slight profit through the first 6 months. North Country has always been able to take care of ourselves. We've always been able to maintain and be in the block. And we've always been able to take care of our community. And that's what we are planning to continue to do. Next slide, please. For those of you who understand billing, because it's such a fun experience, you can see that our days in AR, and this is the real test, and you can see where this correlates directly with where we had loss of money. Our old EMR vendor, we were able to bill and collect in our days in AR with 35. In FY23, that went up to 70 days. 70 days to bill and collect on AR. There were so many problems with the implementation of this system that it's beyond belief. Wrong fee schedules, timely filing issues because we couldn't bill and collect. It led to that $18 million loss. Now you can see we've brought that down dramatically, and we've done so by utilizing an outside billing service. So where we were able to do the billing and collecting ourselves, we now have to spend $2 million plus a year on an outside biller just to make this software function. Next slide, please. So just a quick look at payer mix. NVRH and North Country have the most challenging payer mixes in the state of Vermont. So 16% of our business is Blue Cross. Now I have to break that down, and I don't have it today, and I apologize, but that isn't all Blue Cross of Vermont. That's the Blues from all over the country. We have JP, we have Burke Mountain, we have a lot of visitors that come to the Northeast Kingdom in the summer who are Blue Cross patients, but that's only 16% is Blue Cross, and not all Vermont. Other commercial, 6%. Medicaid, 30%. Talking about the economic difficulties we have in that state. We have expanded Medicaid in the state of Vermont to a larger population, which is fantastic, so folks have insurance. We haven't necessarily brought down more dollars, so every day it's a challenge for us. As Medicaid increases, our costs increase, the reimbursement doesn't. Medicare, it says we're 25.75%, but unfortunately, Medicare Advantage is 15%. Now, as a critical access hospital, we're cost reimbursed on Medicare. But the federal government considers Medicare Advantage to be a commercial plan, which means we have lost any reimbursement from our critical access status to Medicare Advantage. I don't even go to the details of the problems with that, with Medicare Advantage. And then we have others, which include self-pay, workers' comp, et cetera, about 6%. So you can see we have a very challenging payer mix. In order for us to generate 25 cents of net revenue, we have to bill $1. I would say our sister hospitals, let's say in Chittenden County, they would have to bill 40 cents to generate that same 25 cents. So we have a lot of things going against us, but we're making it work. Next slide, please. So I just want to talk about some of the turnaround strategies we made in the last 2 years. How do you go from losing 8 million 2 years ago to being profitable 2 years later? So we do take a look at administration. And I do believe that we've taken a lot of administration out and we've tended to take more. We've eliminated 2 vice president positions. We're also taking director positions out of our system. We've asked people to do more. We've asked leaders to take on more departments. I'm a working CEO. Our IT department reports directly to me. Our facilities department reports directly to me. There's no buffer in between. Those units report right to the CEO. We lagged our CEO hire. We didn't have a CFO when I came on board. So our CEO, who's a former CFO, I'm a former CFO. We took the duties on ourselves for the last year to help in the turnaround. Realigning admin to clinical, as I just said, we've asked directors to take on more areas, and we've taken people who are managers and put them back into clinical roles. Soft hiring freeze. There isn't a position in our organization, whether it's a replacement or a new position, that doesn't go through senior team for review. If it's an administrative position and it's a replacement and we decide to replace it, there's a 30-day hold on that position before they can even post it, to give that leader a chance to see if we can redesign it so that we don't need that position. If it's clinical, more than likely, we're going to do it right away. So this year, with the volume that we've seen at North Country, we're slightly over FTEs in clinical, but we're under significantly out of administration. We made the difficult decision when I came back to close urology. Urology is another one of those services that historically we've been able to contract with a tertiary. UVM supplied us a urologist via contract 2 days a week for over 15 years. They could no longer do it, so we had to hire our own. Now, a urologist is incredibly expensive. And if you're not in an academic medical center where you do a lot of very difficult urological procedures, it doesn't pay for itself. So we made the decision to close urology. Over the last 5 years, we've closed neurology, urology, and we've closed pulmonology. For the simple reason, we're a critical access hospital that can no longer afford to supply those services. We just can't. As I said, we closed our knee and hip replacement. So we have one orthopedic surgeon who's excellent. Outsource our revenue cycle to the tune of 2 to 2.3 million. I brought in Kaufman Hall to redesign our primary care. The other issue we had with our EMR is the inability to utilize the system the way the system needs to be utilized. The amount of clicks that it takes in order for a primary care patient to be seen through this product is obscene. We've had to hire 10 to 12 extra FTEs. We had to bring in AI in order just to make it work. So where we were seeing historically on our old system, 18 to 22 patients a day in primary care, we were down to 12 to 14. So with Kaufman Hall help, we're able to redesign primary care. We're back up to 16, but it's costing us more money just to see those 16 patients. We have a complete travel freeze on for our organization. People aren't allowed to travel anywhere. Some of the things I didn't put on there, we had a 2-year capital freeze, but we've now been able to stabilize and invest again in capital. So we're actually moving ourselves in the right direction. Next page, please. And that's what I have.
Good work.
I know.
It's a good work in 2 ways. One's you finished in a timely fashion, but the other is good work that you're doing. Thank you for that. And we'll save our questions and probably comments for later, but appreciate the work that you're doing, both systemically and locally.
Thank you very much, everyone.
We'll get back to that. Yeah, I will have a couple of questions at the end.
Thank you.
Michael Costa is here from Gifford. Thank you.
Good morning. Thank you very much for bringing me here, allowing me to testify. My name is Michael Costa. I serve as president and CEO of Gifford Healthcare, which is in Randolph, but has clinics throughout central Vermont, Berlin, Chelsea, Bethel, in the heart of Randolph, and Rochester. So my background, for people who don't know, is I moved to Vermont about 15 years ago. I started working first at the Joint Fiscal Office. I transitioned from taxation to healthcare. I'm an attorney by training. I started working for Governor Shumlin as Deputy Director of Healthcare Reform, working on universal healthcare projects, both single payer and the all payer model. When Governor Scott took office, I went and served as Deputy Commissioner of the state Medicaid program. So I'd seen sort of the healthcare system from the policy lens and then the insurance lens. And I picked up a master's in healthcare delivery science and then had this moment where I thought, I have all these opinions about healthcare, but I've never worked for a place that cares for people. So I wanted to go do that. And instead of going to Dartmouth or UVM, I went to the Northeast Kingdom, where I served as CEO of Northern Counties Healthcare, which is a federally qualified health center and home health and hospice agency serving the most remote part of Vermont, as Tom Frank just said. And I've seen all the same press headlines that board member Holmes put up on the screen. And I decided to take a job as a hospital CEO anyways, this past October. And when the Oliver Wyman report came out, between when I accepted the position and when I started the position, my spouse turned to me and said, "That's not your hospital, is it?" And I said, "Yes, it is." And she said, "Well, talk to me about that." And I said, "This is precisely why I want to go there, because I happen to think that if the healthcare system is reduced down to just the UVM Health Network and Dartmouth Hitchcock, that something will be lost in our communities that will not be restored." And so for me, it's a very exciting time to be in healthcare, because this crisis in healthcare is real. And it's no different than Tropical Storm Irene or COVID, where Vermont did an extraordinary job. It's going to involve all of us coming together and working on it and being honest about what we need and what we can do. And so I came into Gifford this past October after it had several very difficult financial years. And I said to our team at Gifford, there are things that we're going to do and things that we're not going to do. We're not going to deny that this crisis is real. We're not going to deny that the problems in the Oliver Wyman report are real, because while we may disagree on some of the data, the underlying point about sustainability is real. We're not going to deflect and say, well, geez, it's really this, it's really that. What we are going to do is be leaders. We're going to look in the mirror about what our communities need and what we can do about it and try to make steady progress every single day. And so when I talk about that specifically with the team, I say, okay, you need to do two things. You need to figure out how to run an organization that's sustainable financially. That's non-negotiable. Tom Frank talked about a lot of the same things that we do. We had an EHR implementation that went fully awry. I was working in spreadsheets this past week. One of the promises they make you at law school is you never have to do math again. Not true. So I was in the spreadsheet and I realized with our new EHR, there's a service line that we haven't billed in 18 months, providing services, not receiving payment for it. To me, that's a great thing to find, because we can go fix that. We can fix that today. So we need to run a sustainable business, and that monkey is on our shoulders, and we have to do that and all the hard work that goes with it. But then also what I tell my team is that we have to find ways to be systemically important to Vermont's healthcare system. And this is really about allocation of resources. So let's talk about those two things. On financial performance, we are trying to improve every aspect of our business. March was the busiest month we've had in a really long time. Our inpatient census was creeping towards 20. If we're not there, those patients need to be absorbed by UVM and Dartmouth, and UVM and Dartmouth are full. We've had a really busy time in primary care, which is great. When I came to Gifford, we had waiting lists for people to get appointments. We by and large fix that through fixing our scheduling practices and our culture to create more access to care. And we're starting to see that in our performance. March was our best month financially since I've been there. Do we have a positive margin yet? No, but we're heading in the right direction. Also, we've tried to do all the same cost-cutting things that Tom described. We eliminated several vice presidents. We just don't need that big of an administrative infrastructure, and that money should go into patient care. We have joined with other smaller Vermont hospitals on a new group purchasing arrangement where we think we can save significant funds by buying things in a smarter way. We've cut several service lines that are just really small. As board member Holmes points out, Vermont's hospitals have to be very careful about trying to figure out what exactly the community needs and not just trying to be all things to all people. We've tried to cut the middleman out of our billing. I inherited kind of a hideous billing situation where we hired a consultant, then that consultant outsourced it, and like, let's be done with that nonsense and put that money into patient care. And so I think we're making steady incremental improvement in running our organization over time. And as we improve our revenue cycle and how we schedule, it will help both access to care and the hospital's finances. And I say hospital, but I hang a little asterisk on it because Gifford, of course, is not one thing. It is a federally qualified health center. It's a critical access hospital, and it's a retirement community with independent living, a nursing home, and adult day. And during our budget process between now and when we submit our budgets in July to the Green Mountain Care Board, we have to take a hard look at every single service line. What can we sustain in this community? What makes sense for us? And thinking about what our community needs. I want to talk a little bit, though, about this idea of being systemically important. And we're pursuing that in several ways. One, we know that on any given night, Dartmouth or UVM is full. They are full of people that need hospital level care. Not all those people need Dartmouth and UVM care. Dartmouth and UVM do extraordinary things, and they should focus on those patients that require that level of care. And so our nursing team is on a call every single day with Dartmouth Hitchcock to say, look, we provide great inpatient care. We have more specialists than you know about. You can transfer some of your acute people to our hospital, and that eases pressure on you. And so we have this idea that we can be systemically important by serving as sort of a pressure release valve for larger hospitals. That is going well with Dartmouth. And I was very pleased to hear Dr. Leffler testifying at House Healthcare last Thursday. If you check out the YouTube videos right around the 23-minute mark, not that I was checking or anything, where he talked about, hey, we need to do a better job at swing beds with Gifford. And I would say, yes, Dr. Leffler, and acute to acute transfers, because we can do things that would really help you and help us. We want to be a lower cost alternative. We've gone to Blue Cross and Blue Shield and say, hey, can't help but notice you're in the news too, right? You're trying to find high quality care at a manageable price to keep Vermont affordable. How do we do that? You must have beneficiaries that are waiting a long time for care at other sites of service in Vermont. How do we do a better job getting some of your beneficiaries to choose Gifford? And as an insurance company, talk to us about the price that you would want to pay for that. We know that partnerships have to be a win for everybody. Because in Vermont, it's not really about competition, it's about collaboration. How do you get the right patient to the right place at the right time? These are the kind of things that I thought would happen under the ACO. Obviously, that did not happen. And so we're trying to reach out to our colleagues at other bigger institutions and Blue Cross Blue Shield to say, hey, can we be a lower cost alternative? And I think that works in a fee for service system. And it also works in a value-based payment system. If you're in a global budget, you're still trying to find the right level of care and the right cost of care. The other way in which I think Gifford could be systemically important is by training the next generation of primary care physicians. There is a movement across the United States called the Teaching Health Center. Many of you have heard people talk about the Maple Mountain Consortium. And it's really interesting to me that in other states, health centers serve as primary care, family medicine, residency sites. But even though Senator Sanders was instrumental in setting up that program, we've never had it in Vermont. So there's been an effort over the last couple of years, starting with the Memorial Health Partners and eventually moving to Gifford to try to get accredited as a primary care residency site to train the next generation of primary care physicians. Because by and large, where you do your residency is a very strong indicator of where you'll actually buy a house, raise a family, and serve as a doctor for a long time. And so I'm very pleased to let you know that we found out yesterday that the program was accredited by the ACGME. And so we're excited about that. We do have a legislative ask for funding. I know it's a bad year to ask for money. But residency programs tend to be self-sustaining over time. You get a federal grant. And then when those resident physicians see patients, you get paid. But there is an on-ramp to get up to a full complement of 12 residents. But we're in a position now where we could do that. And you need to have the specialties and the various other service lines for those physicians to have proper training. And so we're really pleased to be able to say, okay, that could be a lane for Gifford and other members of Vermont's healthcare community to help train, bring physicians here and help train them. And so those are the type of things we're working on. Now, there are many other opportunities, and we're actually really grateful to have the help of the Rural Health Redesign Center. So far, when I've talked to Tom Harlow and people at RHRC, I've been very impressed by how practical they are. A lot of times, and I know I've been involved in some of these efforts, Vermont's healthcare reform conversation can be very academic. It can be very up in the clouds. And part of that is really wonderful to be a part of because it's in service of improving lives and improving communities. But what I've learned when I talk to my colleagues from government about being out in the healthcare industry the past number of years is that you can have all the big policy ideas you want, but healthcare works 24/7. It is an operations game. Your clinics are open, your emergency department's open, your OR is open, and you have to keep it running. And so I find so far Rural Health Redesign is very committed to trying to analyze and solve practical problems within the healthcare system. And so we signed up first as Gifford to get their technical assistance. I think all of our colleagues who run hospitals in Vermont have signed up as well. But we're very interested in talking to them about, hey, what do you see? What do you think Vermonters need? And I'll give you an example from surgery. I love our orthopedic surgeons. They are great. I get to talk hockey every single day. It's one of our orthopedic surgeons is the surgeon for the US men's national team in hockey, right? And I have 2 goalies at home because even my hobbies are stressful. I go to a hockey rink and watch small children play goal. But it feels strange to have your sustainability plan be the 14th hospital going after orthopedic surgery. That doesn't feel like a great allocation of resources. But I have to assume that when we really dig into the data at UVM and Dartmouth and other places, that there are unmet surgical needs that Gifford or some other place could step into and get access to care at the right place, right time, and right price. And so, but we need a technical partner. Vermont's critical access hospitals, by and large, or I guess just speaking for my own, we don't have a giant data analytics shop, right? We need this kind of practical help from someone like RHRC. The other lane in which we're looking to distinguish ourselves is with women's health. We have a birthing center. We're fiercely proud of it. It was really the first place to offer midwifery care in Vermont. We're talking a lot about how we make sure that, particularly right now with our relationship with the federal government, how we continue to offer a full complement of women's health. The economics of running a birthing center are really difficult, but it's a really joyous place. We had 6 babies in there the other day, which for us is a bunch of babies. And it was really fun. They did definitely shoo me out there. Like, we have a lot of work to do. You're kind of less helpful in the birthing center than you might believe, Michael. Move along here. But we really think that there's an opportunity for Gifford to distinguish itself, whether just as a general matter or in some sort of regional center of excellence model. And so I think overall, I didn't bring a slide deck because one of the things I value most about Vermont is it's one of the last legislatures where we can actually have a conversation. I worked for elected officials in Massachusetts, Wisconsin, and California before coming here. And generally there was an army of staffers like me creating a barrier between the public and legislators. And so I wanted to come here and say, if there's any doubt that hospital CEOs don't get that we're in a crisis, I don't think that's the case. I think the silver lining of the Oliver Wyman report is everybody understands we have to change. And so we pivoted from what we need to do to how we need to do it. And we're really engaged with that every day and trying to be very open about what the possibilities are. 2 things that I do hear a lot, though, are, hey, in light of the Oliver Wyman report, Gifford's going to have to close its inpatient unit. I haven't seen that mathematically or financially yet. If I came to that conclusion, I'd be the first person to tell you. I also do wonder if our inpatient unit closes, right now, those patients would go to a higher cost of care setting that is routinely full. And so someone would have to explain to me how that saves money and creates access to care. The other thing that gets talked about a lot is rural emergency hospitals. And I guess as Vermont has a discussion about rural emergency hospitals, which is where your inpatient unit goes away, nationally, my understanding is that's usually a strategy to try to keep a hospital open. I have not read a lot of literature about it being a way to save money for the whole system. And so I think, as people start talking to you about different types of hospitals, I'd urge all of us to dig in on okay, what's the purpose of this tool? How is it really going to work? How does it affect access? Does it really save money for this system? And I haven't got to the end of my own exploration about that, but it's come up enough where I just wanted to address it here in front of policymakers. Most importantly, thank you for having us in. When I stand in front of our workforce, a workforce that I have to tell you has not regained its confidence since the Oliver Wyman report, because they just kind of feel like the next shoe is going to drop in healthcare. And there's a lot happening outside your control at the federal level that's driving that too. It really means a lot to them that our voices are heard in the State House and that we're part of this conversation. Because I think for our team, the nightmare scenario is that, hey, based on this consultant's report, something's going to happen to us without our discussion. I have a lot of faith in Vermont's policymakers that it's going to be an ongoing dialogue until we figure out what's best for the state and for Vermonters. So that's all I have. I'm grateful for the opportunity to testify. I look forward to working with my colleagues at UVM, Dartmouth, Blue Cross Blue Shield. I would urge you, amidst a sea of competing financial priorities, to consider funding the Maple Mountain Consortium, because it actually would be up and running this July if we can get an appropriation. And I'm always happy to answer your questions. It's always a good use of our time. Thank you very much.
Thank you for your comments. They're very helpful, and we appreciate the work that you're doing on all this. And as we finish testimony, we might have questions at the end.
All right, I'll be here.
All right, don't go away, please, in many ways. Robert Adcock is here. Thank you for being here from Springfield Hospital and being patient.
Good morning, everybody.
Morning.
Thank you so much for inviting me to come before the committee. I think that I have a few slides they're going to put up for me.
Perfect.
But I also wanted to take the opportunity to use this forum to also recognize our hospital family back in Springfield and the work that they have done, because we owe a debt of gratitude to that group, because they've been through a lot of challenges. And, in many ways, the situation that we're in the state here, Springfield encountered a lot of these same difficulties 5 or 6 years ago. And when you saw the hospital begin to have difficulty 5 or 6 years ago, that was the byproduct of a number of years of difficulties prior to that, before it threatened the sustainability of the hospital. So I owe a big debt of thank you to our community for sticking by us and supporting us, and our hospital family that have stuck with us and done the hard work as we have charted our path forward in an attempt to move the hospital back to financial sustainability. So first slide, please. Whoever's my clicker. First off, my first slide is kind of rhetorical. Obviously, we know this. Healthcare in America is in a complicated and precarious situation. We certainly know that the federal government, everything's unstable about our federal sources of funding and how our healthcare system sits on those dollars right now. In the state, we have multiple financial pressures, and my colleagues, as well as the Green Mountain Care Board, have already outlined those problems. We recognize those and know we have to work as part of that team and collaborate to do what we can do to make sure healthcare is available to Vermonters. And then, of course, in our local level, everything is very fragile for us in Springfield, but it's improved greatly. And I'm going to show you that as we go through here. So what have we done and where are we at now? And so our progress has taken a while, and we don't know how long it's going to take. I think a lot of people believe that once we emerge from Chapter 11, that the hospital everything would be rosy at the hospital. And that wasn't the case. at the end of my first month there, my CFO called me and told me that we had 6 days of cash on hand that day. And so obviously you're new to the state, new to your job. I hadn't even figured out where I was going to live yet because it's hard to find a place in Vermont to live, right? And my CFO's on the phone and says, Bob, I just wanted to make sure you know that we only have 6 days of cash. And so, oh, great. So that was my first real challenge test when I arrived in Springfield. So first off, let's talk about the trail that we've blazed. And I don't want our colleague hospitals to follow us down that trail, but I'll tell you what has happened to us. So we started out as one of a handful of hospitals in America where our local federally qualified health center owned the hospital. And there was only a handful of those in America. It's a brilliant idea. It's a brilliant idea from a cost and financing mechanism for healthcare. But for us in Springfield, it didn't work and it contributed to the future financial problems that we were going to have. So the hospital went into Chapter 11. I think everybody probably knows that we had to restructure and seek protection under Chapter 11. And during that time, a lot of the cost cutting and analytical work that we've talked about being done in the marketplace was done at Springfield. And a lot of tough decisions were made as a part of that. We cut costs, we reduced staff, we changed programmatic offerings that we had at the hospital. And then we successfully emerged in December of 2020. So 4.5 years ago, we emerged from Chapter 11 into 2 corporations, which is also a very good business model for our marketplace too. So now our local federally qualified health center, which is known as North Star Health now, and the hospital are two separate businesses with 2 separate boards. And they're able to take advantage of the reimbursement available to them on that side. Although I will say that all of the FQHCs in the state are struggling financially as well. If you haven't heard from some of them, you probably will be, because the cost of their care, the same factors that are driving up healthcare costs in the hospitals are also doing that in those clinics as well. And it's really squeezing those guys as well. But we're divorced now, but we're the closest of friends because they provide the primary care healthcare access in our market, and we provide the specialty care. We have built a new strategic plan around that care and around what we believed were the needs from our community health needs assessment. So what are the things that are appropriate in a town of 10,000 like Springfield, in a service area of 30,000? What are the things that are appropriate that we should be doing there? Even though we're in a much different market, say, than my colleague, Mr. Frankie is in the Northeast Kingdom, we do have other hospitals that are much closer to us, but that also drives more competition for wages and competition for physicians, for employees, and all those things. So it's a competitive market from a wage standpoint. And again, we have all the systemic problems that everybody else in Vermont has. Housing, cost of housing, and those sort of things. We don't want to see our hospital taken away from our community, because that would be a real economic setback for our community going forward. And we see an average of 36 patients a day in our emergency department. And that spikes to 50 some days. And both of my colleagues that have preceded me have talked about the difficulty in transferring patients. So there is care that is appropriate for a critical access hospital to provide, and there's tertiary care that should go to a center of excellence. And quite frequently, like almost every day, certainly every weekend, there are bed shortages at our academic centers, at Dartmouth and at UVM. And a lot of our tertiary transfers, when they're full, we send people to Albany, New York all the time, right? So it's a 2-hour trip. Sometimes people go to Massachusetts. Occasionally somebody will go to Boston, but if it's not Dartmouth, it's usually Albany for us. And then if we find a bed somewhere else, then we have to find emergency medical transportation to get that patient there. So if we weren't there, we wouldn't be moving people that were having strokes and heart attacks to higher levels of care. We'd be moving people that had congestive heart failure, pneumonias, basic medical care that we do a great job taking care of. And I will say that all the care we can offer, we do it at a lower cost than tertiary centers would do it. And some of that medicine would be offered outside of the state of Vermont. So some of those Vermont healthcare dollars, if we weren't there, would be exported out of our state. So again, going back to our history, we developed our new strategic plan several years ago after I arrived about what are the things we think we need to do. And obviously, we want the hospital to be financially sustainable. We want to focus on our core services, our culture of caring and being a family hospital, that everybody in the community knows. Quality, improving our quality. And a big thing that can't be overlooked for our particular hospital is our infrastructure, because those years leading up to the financial difficulties of the hospital, there was not money available to reinvest in medical equipment, in infrastructure for the building. So we're now working on things like air conditioning systems, medical equipment. And we also lost quite a few physicians in that thing too. So we're recruiting new physicians. Again, we're the specialty care. North Star continues to be our primary care partner in the marketplace, which is a good system for us. Next slide, please. So what happened when we went through the financial restructuring? Well, we made a really tough decision prior to me being there to close our childbirth center. Now that decision, in light of the geography in our area, was a tough decision for Springfield, but there are other alternatives for obstetrics in our area. The reality of that situation is that many of those people choose to have their babies out of state, particularly in New Hampshire. So a lot of the people, when they're selecting where they're going to have their baby, they're not choosing a Vermont hospital to go to. We had a reduction in force, eliminated a lot of employees during that time and restructured how we run the hospital. Wages were cut. And again, I want to point out to everybody during this phase, which was also at the height of the pandemic, the other hospitals in America were benefiting from PPP reimbursement. And since we were in Chapter 11, we were denied that funding, which would have been probably more than $3 million of cash that we were not able to get because we were in Chapter 11 and we didn't qualify for the assistance. We were fortunate that we were able to get other grants during that time that helped us be sustainable and keep us afloat, but no PPP funding for us. And when we talk about our days of cash on hand, you'll see why that's still important. That not having that funding is why I got the phone call that we were at 6 days of cash, because people were not busy because of COVID. We kept our employees working to salvage our workforce. By the way, we were also the mental health provider for COVID patients for the state of Vermont during the pandemic. So our mental health unit was where we put COVID positive mental health patients during that time. But anyway, we were at 6 days because we didn't get those grants like other hospitals did to sustain them. So we have continued to follow this strategy. How can we be efficient? How can we do it better, faster, cheaper? And again, we are very collaborative. We collaborate with everybody. I call, and I'm like the proverbial neighbor borrowing a cup of milk. I call all of our colleagues and ask for help all the time. And sometimes we get help and sometimes the hospitals can't help us. But we do collaborate with everybody. We have partnerships with Dartmouth, with UVM, and work very closely with all of the geographic partners that are closer by to us. So we're like I'm always borrowing a cup of milk. I'll just say that. So what's our strategy? So, as we move forward to try to move the hospital forward, and again, our strategic plan, this kind of predates Oliver Wyman, and some of it flies in the face of some of those recommendations. But we know that during our financial difficulties and during the pandemic, we lost a lot of volume. Like right now, we're seeing about 13,000 visits a year in our emergency room. And that number 7 or 8 years ago was 17,000. A lot of patients have left our area due to lack of confidence during our financial difficulties. And we're working really hard right now to re-establish that confidence with the patients in our market. So we're a hospital, I would say, that has growth without population growth, because of the patients that are now leaving our area. And predominantly those healthcare dollars are leaving the state of Vermont. Those dollars are not being spent somewhere else in Vermont due to our proximity to New Hampshire. right? So any patient I can bring back that lives in Vermont, that is helping Vermont, it's helping our hospital. And for the most part, any services we provide costs less based on all the data that we have available to us. So we're targeting outpatient services, being the place where you can get an X-ray or a lab test, where you can get a CT or an MRI. By the way, we have Dartmouth radiologists. So if you have an MRI at our hospital, the Dartmouth radiology department reads your film and the result shows back up in our EMR as soon as they release the report. So you're getting the same care as Dartmouth. If you have a surgery at our hospital, EVM pathology will look at your surgical specimen and you're getting the same pathology care that you would get in Burlington from that group there. And so those are just a couple of examples of the things that we collaborate on. And so, you know, we ask and share all the time, but we think our strategy is a win-win-win. You know, we bring back Vermonters to Springfield. They spend Vermont dollars taking care of themselves in Vermont. It costs less than sending them out. And the byproduct of that, getting those patients back, is to strengthen our hospital financially and make us more sustainable. So it's a win-win-win. Next slide, please. Just briefly talk about a few of the things we do. And these are the services that we have locked in on as our core services, the things that we think are appropriate for our hospital in our marketplace. I will just point out, anecdotally, we lost a fantastic female general surgeon from our hospital last year. Her spouse was unable to find a job in Vermont, and he found a job out of state, and that doctor relocated out of state with her spouse because he was unable to find employment in state. At the end of May, we will be replacing her with a new doctor that we've recruited from Maine. So general surgery is very important. If you're a patient in our emergency room in the middle of the night, it's a very important on-call service for us. We have very busy podiatry. Like Tom, we also have an ENT doctor. We have one every 4 days a week, and that almost very, very difficult to get an ENT appointment at some of the tertiary centers, but we have some of the shortest specialty appointment times of any of the hospitals in Vermont. And when you see those numbers published, you'll see that ours are quite good. Very busy orthopedics. We have part-time urology. One of the big decisions we made when we closed the childbirth center was what are we going to be when we grow up in terms of women's health, right? Because we're no longer delivering babies. At that time when I came, we had 2 part-time gynecologists that were coming, but we of course, had closed the obstetrics. And so we made a decision that we should stay in the gynecology service line because it's so needed in our community. You know, so we have 2 female board certified gynecologists who work full-time in our hospital, and they're very, very busy because again, it's so difficult to get appointments with these specialists at other places. So it's easy to say, well, care can go from Springfield to those certain unnamed hospitals in New Hampshire because they're not very far away. But how long will it take to get an appointment and when will they be seen? And again, Vermont dollars staying in Vermont. Vermont patients who have difficulty getting somewhere else can get to Springfield. You know, we have patients at Springfield who come to our hospital to do telemedicine tertiary visits with doctors that we don't have at Springfield because those patients either can't get to the academic center for transportation, or if they're sitting at home and want to do a telemedicine visit, they A, don't have a computer, or B, don't have Wi-Fi so they can do a telemedicine visit. So they come to our hospital and we dial them up and they see their doctor. And that's the only way they get seen. Adult daycare, we have a great program with that. Really good rehabilitation and outpatient therapy program. And we have had 2 services that we've lost. One of my colleagues mentioned that sometimes the tertiary centers can't support us. But we had Dartmouth cardiology 2 days a week at our hospital. And when that doctor also relocated out of state, and they were unable to replace that doctor. And so now we do not have cardiology. And we also had Dartmouth oncology, and one of their doctors retired, and they were unable to support that service when that doctor retired. So those are 2 that we think are needed, but we have not because it's so expensive to recruit a cardiologist or an oncologist. We've decided right now we're gonna stay the course on that. Next slide. Operationally, we're still following through with our post-Chapter 11 improvement plan. Big thing with our hospital, I heard it from both of my colleagues who preceded me, is revenue cycle improvement. They talked about having EMR woes. Well, we have 3 EMRs at our hospital. So, so we have a lot of EMR opportunity. We would certainly benefit. I know there are talks about having statewide EMR products available for the small hospitals. We would certainly benefit from that because we have a lot of challenges around trying to use 3 EMRs. And by the way, our primary care FQHC has a 4th EMR. So we have our doctors working in some cases in 4 different systems, which is not conducive to efficiency. We regionally collaborate with everybody and trying to partner. You don't think I'm calling everybody and asking them if we can borrow their cardiologist a day a week? Yes, we are. And again, trying to avoid duplication of services. One of the things we have closed recently was our pain management program. It was not utilized very heavily. And as we were defining what our core services are, we determined that wasn't a core service for us because it was elective and people can, have more leeway on making appointments. So we closed that service. Next slide. Kind of moving over, as my colleague said, we're also looking forward, to the rural healthcare redesign group looking at our hospital because, there's been a lot of talk about rural emergency hospitals, particularly as they apply to Springfield. And a lot of people have felt that was maybe a really good option for us. But we have done our own analysis on those hospitals. And our conclusion was that it's not a good fit for Springfield for a number of reasons. One, the finances didn't show an improvement for our hospital. So, we eliminate these inpatient beds. We scale the hospital back to really a basic hospital. And, as the cost goes away, the revenue is going away even faster. And so a rural emergency hospital in our analysis would have to have a very robust ambulatory surgery program to be able to break even. And and we would also have these other risks. Of course, you'd lose our bed access. You've already heard my 2 predecessors testify about the difficulty we have in transferring patients to when we don't have a bed or the patient needs to go. And so if you're having a heart attack in our emergency room, you're going to get moved to tertiary care really quickly. If you have, a pneumonia or a congestive heart failure, it's going to be really hard to find a bed for you somewhere else at one of those tertiary centers. And if we find a bed, then we're going to have to figure out how we're going to get you there, right? Because our EMS colleagues are really stretched. They're losing money and they have the same workforce and inflationary challenges that we have. And so lack of transportation, lack of beds. And again, if we become an REH, we would lose the critical access cost-based reimbursement that we get from Medicare. So, as the volume is dropping, the net patient revenue is dropping with that. And then over on the other side, the money we get from the Medicare cost support has gone away completely. So that whole hunk of money has vanished in the formula. We would also have to give up our mental health beds, which are located in Bellows Falls, because those facilities don't allow for distinct part units. And we certainly believe that our mental health program is important to us. By the way, our provider staff there is the strongest it's been in years. We have an MD medical director there, 2 mental health nurse practitioners that see most of the patients. And we have 3 hospital employed per diem nurse practitioners who cover our holidays and vacations. So we have really strong staffing there. And again, we have a grandfather critical access license. So if we became an REH and it didn't work out, it would be impossible for us to convert back to a critical access hospital because we don't meet those standards right now. So we've looked at this. We're looking forward to the consultants, going through our numbers and seeing if we're right. or if we're wrong. But again, certainly Springfield, we're interested in looking at all these options. You know, what choices are available for us that make sense for us to provide affordable access and quality care and take care of our community. We're not quite as busy, say, as North Country, but we are quite robust. So what's our vision for sustainability? We're on sustainability. Back one, please. Yeah, so again, we're responding to the needs of our community, health needs assessment. And again, in the Oliver Wyman community and provider meetings in our marketplace, that's also what we heard from the community is not surprisingly, our community was asking for more care in Springfield, more access, more care, not to travel somewhere else. Now, if we can figure out a way to make that financially sustainable and to provide that care locally costs less than transferring it somewhere else, particularly if that somewhere else is out of the state, isn't that a win-win-win for everyone in the marketplace? So that's kind of what we're trying to do is get to sustainability. We're reinvesting in our core services, fixing the building, the things that there was no money for when we were in financial, crisis, recapturing our outpatient services, collaborating with everybody that are thought to us, particularly with North Star, our FQHC. So next slide, please. This is really hard to see, but it just shows you a little bit about what's happened the last couple of years as we've emerged from Chapter 11. And again, starting out, emerging from Chapter 11 at the height of the pandemic is without any PPP funding. We had a lot of handicaps on us right there that were going on, and those were all colliding about the time that I arrived at the hospital. But I mean, you can see as we've added general surgery, our general surgery is going up. Orthopedics is a mature program for us. It is stable. ENT, we've actually increased the hours of coverage in that service. It's very hard to get an ENT appointment, around the state. That's a really tough one. Urology continues to grow. So our that service is important. Gynecology, is really rebounded with the two very qualified lady physicians that we have doing that work. Podiatry is a new specialty that we added since I came. There was no podiatrist in Springfield when I came. And so now we have a doctor there who's incredibly busy. And the emergency room remains, we're experiencing a slight growth there year over year. Because again, it's hard for people to get appointments. So do we have emergency room visits that could be avoided? Probably. But when you're a patient making that decision at 1 o'clock in the morning about, what should you do? I mean, it's good that our emergency room is close by. And our inpatient volume.
So I'm going to ask that you accelerate your pace through the slides simply because we have another presentation that is going to take some time, and we'd like to get to a place to ask a couple of questions.
Sure. We'll just briefly hit my financial page slide. You'll see that we've continued to make financial progress in FY22. Our positive margin was basically driven by the virtue of some grant income that we received. In 23 and 24, we've had slight losses, but remember last year we lost $700,000 with no grant income supporting that. And that's from a hospital that 6 or 7 years ago was losing $6 or $7 million a year and was in Chapter 11. So, we've done a really good job turning the hospital around financially. Are we where we want it to be? No, not yet. How long will it take? I'm not sure. We'll probably just skip over. See this slide. I will just say we've done a lot of work on financial assistance this last year. We've done a lot of work around Act 119. We've hired our own patient qualifier who meets with patients and helps qualify them for Medicaid and assistance. But a lot of people, someone said earlier that a lot of people don't cooperate to do that, and we've experienced that too. So bad debt and charity care are both up at Springfield. And right now, year to date, if our charity care and bad debt were running at the same rate they were 12 months ago, we would be positive by about $500,000 through the first 5 months of the year. But so the increase in bad debt and charity care is is the main driver from last year to this year on our finances. So I'll wrap up. Sorry, I was verbose, but I'm pretty passionate about my hospital and I can talk for hours about it.
No, thank you. I think it's really critical that people understand that you have pulling yourself up out of a Chapter 11 situation. So what you are doing is different from what other hospitals have the capacity to do at this time. So it gives us a picture and a window into kind of the diversity of what's going on across the state and what we need to be thinking about as we write policy.
Thank you so much for recognizing that, because I think a lot of people, once we emerged from Chapter 11, thought the problem would be solved. And they underestimated how long would it take in this environment, starting in the pandemic, in this environment with all the challenges we have going on, how long will it take one little step at a time to make the hospital sustainable? And that's our strategy in our business plan right now. So thank you for letting me.
Maybe we could build a team. That would be good. All right. Brendan Kraus is here. And just an FYI, no, we've been sitting here a long time, but what we're hearing is really critical information. And if need be, we'll go over 11 o'clock, I think, for both committees. We've consulted here. And we want to make sure that we get everything we can get out of the important testimony in front of us. So we have two folks here, and introduce yourself for the record. Thanks for being here.
Having us, Madam Chair, Brendan Kraus, Director of Healthcare Reform at the Agency of Human Services.
Hi, everyone. My name is Fran Hodgins, and I'm the Administrative Services Director on the Healthcare Reform team at the Agency of Human Services.
Madam Chair, do you have a sense of how much time you would like us to use? Because
Well, everyone else has taken a half an hour.
Okay.
And so what I think you need to do is to use the time to get your message across effectively. And so there's no barrier.
All right. Well, thank you. And it's great to hear from the hospitals and hear all of their positive actions. However, I'm going to return us to the theme of crisis started by my colleague at the Green Mountain Care Board, Member Holmes, and talk a bit about what is driving our reform efforts at the moment. And again, very happy to hear the progress that's being made, but the situation is pretty dire. So want to just sort of return us to the focus that the health insurance costs and out-of-pocket premiums have gone up substantially over the last 10 years. More than half of our hospitals are operating at a loss. Our insurers are facing significant financial sustainability issues. And then there are the access issues facing Vermonters of not just long wait times, but even just the ability to get a primary care medical home. Gaps in community-based services that I think are somewhat unique to our state in terms of while we have a very strong and robust clinical community health center system, there are a lot of gaps between hospitals and community-based care that we need to address. And we've got, programs like the Blueprint for Health and BCCI that we can build on, but as hospitals face crises, primary care is going to have to step in. And we have significant health-related social needs issues, for Vermonters, such as transportation and housing and food that I've mentioned today. So in addition to the data that Member Holmes presented about how the acceleration has occurred in terms of financial fragility in our hospitals, we've seen some new changes at the federal landscape. And it's a time of uncertainty, and I won't go into great detail because I know that my Medicaid policy colleagues have been in to discuss these more robustly. But the fact of the matter is we are likely facing Medicaid cuts. We don't know exactly what those will look like. We have a sense, but it could not just reduce the discretionary spending that we have for some of our more innovative programs, but it also could affect the populations that are covered because, as has been pointed out, Vermont has chosen wisely, in my view, to expand coverage to many populations that might be at risk. And then, we have the fact that evidence suggests that these cuts will have a disproportionate effect on rural states because, for example, as you heard from Tom from from the country, the payer mix in many of our hospitals is heavily tilted towards the federal government. I just want to, I'll not spend too much time on these slides. I just want to acknowledge, that healthcare reform does not exist in a bubble at AHS, and my colleagues have and do every day very important work, led by dedicated and talented people that are working on transformation in real time, even outside of this project. So just a couple of examples of those are efforts that have been made to reduce wait times for placements for mental health, people experiencing mental health crisis, and also ways to make sure that we're leveraging all of the, for example, special needs beds, so that we're trying to address many of the bed blocking issues, special needs facilities beds, that have been pointed out by previous speakers. I'm sorry, I'm advancing my slides and thinking that it's happening. Next slide. So we're going to refocus in again on the exam question, which was, where are we now with specifically the Act 167 and Act 51? So as you all know, GMCB led a very robust engagement process and analysis process. We have taken those recommendations that were produced through the Oliver Wyman report, and also other activities that hospitals have engaged in over the last several months, and are working, as my very capable colleague Fran will go into great detail about, with our Rural Health Redesign Center contractor partner to analyze those, and are now getting to the stage of sitting down with hospitals and looking at the feasibility of implementation. And then, over the last several months, we'll point out some pretty significant collaboration activities that have gone on, particularly with the Green Mountain Care Board and the Department of Financial Regulation, the Healthcare Advocate, and others that are trying to speed up the short-term work in terms of the $200 million sort of target that Member Holmes and Chair Foster delivered to us, but also in terms of refocusing some of our efforts on the 5 or 6 or 7 hospitals and clinics that are in the most trouble. So this is kind of a busy slide, and I don't want you to dig into the details and attempt to do a snapshot of a work plan. So I'm just going to call out a few takeaways, and then my colleague Fran is going to step through each of these in much more detail, and it'll make more sense then. But just the point here is just to show 2 things. One, we have some of these short-term activities. The color coding is work that's being done by the Green Mountain Care Board, work we're doing together, and then work that's being led by AHS and RHRC. And so the 2 takeaways really I just would want to leave you with are, we have front-loaded the work now to address some of the short-term needs. I'm going to talk about that in the next slide. But also just to show that we're working hard to align the technical assistance outputs with the regulatory calendar. And so the goal very much is to have, rough draft or, significantly advanced drafts of transformation plans for hospitals that coalesce around the budget process for the Green Mountain Care Board. And just trying to make sure that we're always working in concert, because we both have different levers, right? We have policy and funding levers. The board has regulatory rate setting and budget setting levers, and we want to make sure that we're aligning. So just a bit more about the short-term transformation groups. In fact, we meet weekly. We'll be meeting this afternoon here in Montpelier. And the goal is for our 4 organizations to come together to address specifically in the short term, the 5 hospitals that are experiencing the most financial fragility. We'll be having meetings with them over the next few weeks. We've requested financial data. All of the hospitals have actually stepped forward with financial data, but specifically from these hospitals, and we'll be digging in, to their numbers with them and sort of getting their sense of what their plans are and how we can support those plans. And we will be actually retooling and refocusing some of our transformation funds that are going through our contractor to support more robustly those specific hospitals over the next several months. And we'll then be convening sort of a cross-section of reconvening, I suppose, a cross-section of providers in the state to begin sort of a more tactical conversation about framing the issues that are facing the organizations and how best to engage, recognizing the 24/7 nature of the realities that they face and the limitations on some of the administrative resources that they have. We can support those, and specifically looking at ways in the short term we can support administrative cost reduction and streamlining of clinical services, et cetera. So with that, I'm going to hand off to my fantastic colleague, Fran, who will step through a bit more detail about specifically what's going on. And I'm sorry, I should have brought a cup of water with me. It's a mistake.
Give you some relief. Well, hi, everyone. Thank you for inviting us to speak today. I'm going to be sharing a little bit about the agency's work with our contractor, Rural Health Redesign Center, which I think you've heard a little bit about earlier today, and I believe we presented earlier this year as well. So we engaged with Rural Health Redesign Center in January of this year with the goal of sort of optimizing the next step and thinking about the feasibility and operational next steps for the Act 167 work. And just as a reminder, the Rural Health Redesign Center has a decade of experience working with hospitals around transformation type projects. Most notably, they ran the Pennsylvania Rural Health Model. So in the next couple of slides, I'm going to talk through at a high level what the kind of scope of work looks like with them, and then provide some updates on where we are today. Next slide. So I'm going to start by talking about hospital transformation. And again, I think Rural Health Redesign's sort of focus is on what are the operational next steps, the feasibility, how do we move from the recommendations into the changes that we want to see in our system. One of the ways that they will do that is through the provision of technical assistance to Vermont hospitals. They offer a menu of technical assistance services, and we have been working over the last couple of months to identify what do we think are the kind of priority services that are going to be most useful given the challenges that our hospitals are facing. I've noted, oh, sorry, can we go back? Thank you. I've noted a couple of the priority areas that we think are going to be most valuable. For example, we've heard already folks talking about a service line analysis, sort of looking at a group of services to say, how is this performing financially, clinically, operationally? And that gives us some insight and leadership insight into saying, what do we think about for resource allocation? How do we think about strategic planning moving forward? Obviously, these are really complicated, challenging conversations to have. And, thinking about the potential access issues related to any of these decisions is something that's forefront in our mind as we think about how to move forward with these types of analyses. But several of the other things here I think have come up as folks have been talking about the challenges that they're facing, sort of operational analyses, staffing, collaboration and affiliation opportunities. Rural Health Redesign Center has some expertise around global budgeting, so they can provide support around global budget modeling and then financial assessment. So at this stage where we're at is Rural Health Redesign Center is sort of working with the hospitals to collect their data, building on the previous reports and recommendations from the Oliver Wyman report and other reports, and is scoping out what does this technical assistance look like at each hospital. Notably, I think as Brendan alluded to, we have asked them to prioritize technical assistance at sites that are facing serious financial challenges. And we've also asked that before they move forward with any project, there's an opportunity for the agency, for the Rural Health Redesign Center and the hospital to sign off on a scope of work so that we all sort of have insight and agreement around what the type of project will look like. The other component that I want to talk about for hospital transformation is related to the development of hospital transformation plans, and I will get into that a little bit on the next slide. So I like to think about a transformation plan as sort of a roadmap of identifying what are the short, medium, and long-term steps that it's going to take for an organization to go on this transformation journey. The goal is for these documents to be informed by data analysis and stakeholder engagement, recognizing that a lot of that has already been done, but there'll be continued kind of conversations as we move into this feasibility and operational phase of the work. The transformation plan includes the development of goals. Financial sustainability will be a component of the transformation plan, but it can include other things as well, thinking about population health, care coordination, management of chronic conditions, and other goals that could be identified. Access is a really good example. And One of the things that we're hoping to achieve by the development of these transformation plans is also thinking about how each organization's plan fits in with sort of the regional impacts and the statewide impacts, as well as the federal landscape as well. And this is a model in which there's a kind of goal. We're bringing it all the way back to the Act 167 goals, and there'll be the organization's goals. And then it's followed by what are the concrete steps that Rural Health Redesign Center has identified to say, okay, if this is the goal you want to get towards, here are the 12 steps that you need to take, or, you know, the 5 actions that you need to take. What are the costs associated with them, the timeline, et cetera. And one of the benefits of having that type of document is that it can be used as a tool to support implementation, but also accountability over time. And this is a model that Rural Health Redesign Center used in Pennsylvania as well. So the plan for this is to draft these, I believe it's June to September of this year, and then finalize them in the fall. Next slide, please. So that is, like, I would say, the kind of high level of the work that Rural Health Redesign Center is doing with hospitals. But here's where we are today. So all 14 hospitals have raised their interest and expressed interest in participating in the work with the Rural Health Redesign Center. And they've had introductory calls with the hospitals to introduce themselves and the program and kind of get initial questions. A data request form was sent out to all of the hospitals, and the majority of those have been returned back to us. And the RHRC is working to get those final data request forms back. As some folks have mentioned earlier, they'll be up in Vermont the first couple of weeks of May to have one-on-one in-person sessions with the hospitals to talk about their technical assistance project, the transformation goals, as well as review the kind of findings that RHRC has compiled based on their analysis of the data that's been submitted to them, as well as the prior work done through Oliver Wyman and other analyses. Another thing that I want to note here, and this isn't specific to hospitals, but we're also planning for some large in-person regional stakeholder meetings in early June. The goal here is to bring together hospitals, but also other key parts of the healthcare system to talk about the vision, the early findings from RHRC's work, aligning on goals, talking about what are the essential services to preserve in each community, and thinking about what are the elements of success and the next steps to move the conversation forward. Next slide, please. So I've talked a lot today about hospitals and RHRC's work with hospitals, but we know that healthcare transformation doesn't only need to occur in our hospital system. It needs to be system-wide to be effective. And another really important component of that is our primary care system as well. Our work with RHRC also includes an opportunity for up to 20 primary care practices to access technical assistance through RHRC. And so the healthcare reform team has been working very closely with the Blueprint for Health team, as well as practice representatives, the Vermont Medical Society, Bi-State, Health First, and providers to identify what are the types of technical assistance, what are the concerns that we're hearing from primary care providers, and importantly, where is there a gap in the types of services that are available to support these providers, because we know there are already kind of quality improvement and technical assistance opportunities available through other value-based payment models and programs. So what we're trying to do here is target the technical assistance opportunity through the Rural Health Redesign Center to speak to the concerns that we're hearing from primary care practices. So, one of them is financial health and sort of keeping the doors open. Another one is thinking about how do we increase access or sustain access to primary care for Vermonters. We're hearing challenges around staffing and thinking about different models for staffing that could help alleviate some of those challenges. And then also how to keep pace with investments and changes needed in a changing healthcare landscape. So I think, we're, in terms of where we are with primary care, we're a little bit behind where we are in terms of hospital engagement. We're just on the cusp of distributing out a sort of interest form in which we will ask folks to sort of do a self-assessment. What are the types of supports that you need? Where are there areas that you're struggling? And then start to have some initial calls and engagement with Rural Health Redesign Center. But just to give you a flavor, since these projects haven't launched yet, but what I think they might be looking like is perhaps, support around financial and operational changes from funding changes, the sunsetting of One Care Vermont, or the end of the CHT expansion pilot program on things like that. Another example might be how to think about retaining or expanding primary care team staff or thinking about hours and access as well. So I will go to the next slide. Thank you. Okay, this is my last slide. I've talked a lot. I just wanted to flash this back up because I think it might have a little bit more meaning now that we've talked through each of the activities at the beginning. Brendan touched on some of the short-term activities that are coming up, meetings with hospitals, with challenging financial situations right now, talking about opportunities for short-term savings. The work in the green here is really the work that is happening with AHS and the Rural Health Redesign Center. So again, I'll just highlight some of these. We've got these upcoming meetings happening in the first couple of weeks of May with the hospitals. We're planning for a larger in-person meeting in early June. And then the next couple of lines are talking about the technical assistance provision for hospitals and primary care. And the last couple of lines are talking about the development of the hospital transformation plans. So all of this work is planned for this calendar year, and I think it's ambitious. I meant to note earlier that the Rural Health Redesign Center, their work in Pennsylvania was a cohort of 18 hospitals. So this is what they do, and this is the type of scale that they're used to working on. But we still are thinking about how we prioritize within the state, how we think about the areas of greatest need, and that's an ongoing conversation that we're having with hospital or with RHRC about how to best support the hospitals in Vermont. You have anything to add? Great. Otherwise, I'll wrap up.
Thank you for that. And I understand that I'm going to make a couple comments. I understand that in some ways, the delicacy of the work that you're doing and encouraging hospitals to come to the table and to make significant changes. And we can't legislate that necessarily. We can legislate the process. And I also understand the situation that you are in doing the same thing. You can't demand that change be made, though we know we don't have the time. We just don't have the time to spread out. And I think about what the redesign center has done in Pennsylvania. Pennsylvania probably had more time than we have, and potentially more resources. So, but I appreciate the significant work that is going on. But we all have feel an urgency here, and I know that you do as well. But we need to keep that sense of urgency in front of us at every minute. I'm preaching to the choir right now. I get that. I know, I do get that. I do have a question, because it is 11 o'clock, and I know that everyone has had an opportunity to share with us the work that's going on. It's at different levels with different hospitals and different groups. But for me, one of the visions that we put in place, and I'm looking at Lori because we work so closely together on 167, but having the vision of hospital and community transformation to include those services that are outside and beyond the hospital. So those community services that we see for substance use disorder, long-term care. I see sashes here. We're talking about all of those things that are so critical to keep people at home in place. And by that, I mean in their own region, whether it's tied directly to a hospital, to a FQHC, or to other services. So our vision is to move beyond. So right now, we're sitting around the table. We've been talking about hospital financial sustainability and moving forward. For us, we think we'd like to have to be there, that the hospitals have made those decisions. And we can't say that, no, that I know that hasn't happened. When you have a big organization, it takes significant time. So I'm just feeling that urgency. It is really wonderful to see the work that is going on, and in particular with respect to primary care and social determinants of health and how to move toward better transportation or housing, all of those situations that face each of us on a daily basis. One of the things that was mentioned early on is how the boards of hospitals were brought together. each of our CEOs, and this is one of the delicate places we get to, but each of our CEOs is hired by a board. And boards have their own sense of how to save the local hospital. And we know that our local hospitals are critically important to us. At the same time, it would be great. I don't know, I have no clue what goes on at each board meeting. But it would be absolutely terrific to see boards working together as is happening in your area. But that boards are communicating about the urgency that we all feel and sense in this room to transform as you're doing with Rural Healthcare Redesign Center. So that's just my 2 cents. And so my question, if the CEOs could answer it, and if our healthcare reform director, because I know you are the locus of responsibility at this point for moving things forward on transformation. But what, if anything, 2 questions. One, on having the boards engaged in this in a very direct way, and 2, moving toward community service integration. I think of community health teams if you think primary care, but it's beyond that. So those are the 2 questions. And I just ask you to raise your hand and answer for those folks who are here who have brought testimony. And I see the hospitals raising their hand already, so please go ahead.
I'm Green Vermont. Excuse me. Talk to you. I'm Seven Green Vermont Association of Hospitals and Health Systems. We are actually hosting a meeting of all board members on May 2nd and having that discussion then.
Can't hear you.
We couldn't hear you, sorry.
We are hosting all board members of our hospitals on May 2nd and are having that discussion then.
And that's terrific. I must say it's terrific. And if the urgency that we feel can be conveyed to those board members, that would be awesome. Good, Mr. Frank.
So, again, in the Northeast Kingdom, we recognize how critical it is.
Yeah.
We're all in this together. And, as a community, our boards are very supportive of actually working together. We all have our strategic plans, but we all are also discussing how those strategic plans can be incorporated into a universal plan for the entire 2,000 square mile area of Northeast Kingdom. So they're very supportive. Our board they've been amazing, how willing they are to step up and work together collaboratively and not look at us as separate entities.
Thank you for that. Yeah, and it sounds like moving into the action plan that we're considering in Act 126.
I would say our board does not have a lot of status quo bias. It's trying to figure out what the future of healthcare is in Vermont generally.
Yeah.
And Gifford specifically, participating in the meetings at BOS that Devin described. And then also, we've joined recently the New England Collaborative Health Network, which is an association of Vermont hospitals that come together for shared services. And it requires board member participation. It understands that to create a network of hospitals working together, you need board buy-in. And so we're now actively participating in that along with Copley, Northwest, Brattleboro, and other Vermont, New Hampshire, and New England health hospitals and health systems.
Wow, it's great. It is great. And I know the board would like to hear.
So I was just gonna ask, that's the first I'm hearing of that meeting, and I so appreciate that. And I think it would be a wonderful challenge for the boards that are all coming together is to collectively find efficiencies and ways to reduce costs and find $200 million that we can between now and July 1st and move to the system so the premiums are not 20% and they're closer to 5%. So that would be a wonderful challenge for the boards that are collectively coming together to find that path forward.
So yeah, the $200 million is a big
It's a big
elephant
number.
in the room.
Yeah, that it is the number that we have been working with right now to try and bring down premium costs to something that businesses, taxpayers, individuals, and families can afford.
Any other comments?
I would just,
No, I'm gonna.
Sorry, just I'll just quickly say, you know,
I had my second question needs to be answered.
one of the things that we like particularly about the experience of Rural Health Redesign Center is that they are largely made up of former hospital CFOs, CEOs, et cetera, and have said what you just said to us many times about the importance of bringing boards along and have a module for doing so. And so that will be very much part of the work going forward. We just prioritize getting the actual technical work up and running.
Good. Yeah, no, I think that's always a concern with the planning process, is it can go on as long as we think it can go on. But yeah, I did ask a question about community services, but I'll go to our question right here. Yeah, go ahead. I'll ask it again. Go ahead. Your question.
Okay. Sitting here, and I don't want anybody to take this the wrong way, but sitting here listening to the hospital people talk, Green Mountain Care Board talk, it seems like you're all talking about you want to work together, et cetera. But it's fragmented. You're all shaking your head that way. So what are you doing about that? Because until you get to that point, all the discussion that you're having, let's be honest, it's not working.
Well, we don't know it's not.
Well, I do.
Oh, okay.
I absolutely do. Well, that's why we're here today. We've got a massive problem.
Yeah, you're right.
I'd love to respond to that. I don't disagree with you at all, sir. We're not a system. We keep hearing healthcare system. We're not a system. And we're trying to work together as a system, but we're not. The only system that exists really in Vermont, even what Mr. Costa is saying, is UVM, Porter, Central Vermont. That's a system. Okay? We are not a system. BOS does their best to try to bring all the CEOs together to work on collaboration, to work on the economic and financial problems that exist in the state, but we're not. I am one of the CEOs that wish we were. Because if we were a system, I wouldn't have to be fighting, scratching, and clawing to get services in the Northeast Kingdom. The mothership would be able to allocate and help. I don't have that. I don't disagree with you.
First, we need a mothership.
I would agree with that.
So Representative Goldman and Representative Houghton each have questions. We'll start here.
Yeah, thank you. We are working on S-126, and some of you may be familiar with that bill that came to the House from the Senate. And we've heard over the last testimony we're taking about an emergency plan. And I'm wondering what constitutes an emergency plan, and if that's something that we need to think about involving embedding in S-126 or another piece of legislation. So I'm not sure if that's for you, Dr. Holmes, or someone who might help me understand what an emergency plan might look like. Because $200 million by July 1st, wow. And that's a big ask. And so what do we need to have in place by then? Should we not have $200 million by July 1st?
Yeah, thank you. That is a really good question. And I know that there are some measures. I think it's in H482 that allows the board to intervene in the cases of insolvency of, domicile insurer. I think that offers us some emergency authorities to reduce some prices, to save the solvency of that insurer. I think that's really important. I would like to see this collaborative effort not get us there. I would like to see the hospitals and the boards find creative solutions to reduce administrative overhead, find shared service opportunities to do these things that we've been talking about here, that we're hearing from some hospitals that they are doing. My concern is that the time horizon is really, really short. We're not there. I'm hearing wonderful strategies, medium run and long run strategies is what I'm hearing. And I don't know how we can afford waiting for the medium run and long run strategy. So I think that there are some S-126 has reference-based pricing in it. That's going to take some time to implement. It has a review of the network, of UVM Health Network, to decide if the efficiencies we're supposed to be seeing in the network are actually materializing. Those are all medium run and long run strategies. I think the emergency measures and giving the board some emergency authorities to try and reduce some prices and to
So I'm gonna, see, this is it is definitely a top of the list issue. It's also a separate issue and it's one that our committee will be looking at, and I think your committee will be looking at.
Okay.
I've already engaged a discussion around language and where it might go. So let's hold that thought on the $200 million. That is an emergency and we have been thinking about it. But I do want to make sure that we continue looking at what we've heard today about next steps, regardless of what happens with that $200 million. All of our hospitals and our community services need to be prepared. And to prepare, they need to know what they have and what they could have and how they can transform. So I'm not to shut off the good thinking on the $200 million issue, but to keep us focused today on where we are. So I'm going to move to Senator. Oh, you just got promoted.
So I am, with all due respect, gonna stick on this 200 million for just another moment. Because I would like to know, I would like to hear from AHS, not just the Green Mountain Care Board on this issue. And I also want to know who is accountable to get us there.
I would suggest that as a team effort in terms of the regulatory plus, AHS plus, the governor's office functions. So our next step is convening this initial group to lay these cards on the table and say, this is what we're looking at. These are the realities. What can we do?
I think folks behind you probably can't hear.
Oh, I'm sorry. What does this look like? I mean, this is a unique ask and we need to, join forces and sort of look at what can actually realistically happen and by when, and without causing collateral damage, because, moving fast in healthcare is often important, but also often dangerous. So I think we have to be sensible.
So I'm following very fast.
I got one more. I'm going to add to after you go ahead.
Okay, and we've had this conversation before. Act 167 report came out almost a year ago. We've been hearing it's a collaborative effort. We all have to come to the table. I appreciate what the hospitals are doing. I think after the initial, blow up of the Act 167 report, some of the hospitals are really coming to the table quite well, but we still don't have a system approach. And now we have this $200 million on the table. I would love to see what these hospitals are doing, what the financial impact is. And have you all come forward with a plan that says, this is how we need to get to 200 million. I love the process that you're doing with the consultant. And if we had the time, that would be amazing, but we don't. So we almost have to work backwards in some regard. That's what I would like to see.
Yeah, 100%. And we agree with you. And that's why we are pulling forward reprioritizing some of the resources, then we do that over the next 2 months.
But it doesn't seem like that with the plan. So that's my last.
Okay.
statement.
Yeah,
Thank
so
you.
just to echo your concern.
Yeah.
The concern is that we can't wait for change to happen. We need to direct the change. And sometimes that's uncomfortable for the folks who are being directed. That means boots on the ground, being directed to change. So we haven't done that, but with $200 million looming, I think what Representative Houghton and Representative Goldman have said is there needs to be direction.
I agree.
Yeah.
6 months ago, it was 400 over 4 years and now it's 2 in a month ago.
And who knows what it will be in a month when we get the
Right.
Medicaid cuts.
Okay, Representative Rebecca has a question.
I do.
I thought you had your hand up. Did you?
Yes, I did. I said I do have a question.
Maybe it's a comment.
My question is about a case study you provided at the top of your presentation around the reduction in wait times for mental health crisis bed placement. I agree, we've made great progress there, and I think this is a great example of where transformation is possible. And you cited 3 things that really got us there in terms of steps that were taken. One was expansion of available mental health resources. Another was extraordinary financial relief. And I just want to call out that I think during that time frame given, 2020 to 2024, the extraordinary financial relief, I guess that you must be referring to the COVID relief.
I will have to follow up with you about that. It was a different.
Because I'm not aware of any budgets put forth by the administration that increased during that time that it included anything other than COVID relief.
Okay, we're happy to come back with you.
And in terms of expansion of available mental health resources, mental health urgent care and mobile crisis, as well as 988, which was a federal program that's federally funded, the implementation was. Those two concepts really came from providers, HCRS, and then I know Vermont Care Partners did a lot to really bring those up to scale with the support of AHS. Additionally, we've recently invested in mental health supports through the Blueprint. And I just want to note that in this case, I think one of the steps taken that isn't highlighted here is that AHS listened to the innovations and the voices of our providers. And you listened to where successes were happening. We did the Rutland pilot of mobile crisis, and you scaled it up. And I think I would like to see more of that, more of working with our providers to listen to where their successes are, more of lifting those stories up. But I would also like to see more requests for money to do it. We can't do that alone in the legislature when you're giving us budgets that defund mental health. Thank you.
Thank you. So you can't respond to that. I understand that, but it is, there are ongoing concerns. I think my second question that wasn't answered, and it is the question about community services and the integration of community services within the transformation process. If I could get like 10 seconds from someone on that, because we've got long-term care, we have early care, we've got everything that's needed in terms of counseling, mental health, substance use disorder, and those that continuum of care that's so critical. We can't continue to focus only on the hospital transformation internally, but how that relates to the full system of care. So I mentioned the social determinants, et cetera, et cetera. So comments from folks who are in that embedded that we've heard from, embedded in the transformation process, and what you're seeing with our community-based services.
I would say, Giffords and FQHC, a hospital, a nursing home, we have this all in our. The challenge financially, candidly, is that the hospital has subsidized those services for many years, and now it's unable to. But I think that's going to continue to be a strength, having those together. I think what we need help with Rural Health Redesign Center and others is we're sitting on a mountain of data about those folks. How do we do a better job of preventative care and moving them upstream? Because we have the problem of, we're big-hearted Vermonters. We're very good at taking care of Mr. Jones. We should do a better job of having a conversation upfront with Mr. Jones of, hey, based on what we're seeing, here's what we think we can do to keep you out of the hospital or, in your house before you go to one of our limited nursing home beds. And so we think we need to take sort of the community wisdom, infuse it with data, and do a better job of that. And as we get to things like hospital global budgets, we think we'll have financial means to actually do. I hope that's responsive in some way.
No, that's a terrific response, and I appreciate it. I think that we're actually at the end of our time this morning. I will say that each one of you has given us really great testimony. I don't want anyone to think that we haven't heard important messages today from you, and the work that you're doing is critical. You've also heard a high level of frustration, I think, both from you and from us about lack of resources, time and money. We don't have time. And by golly, we're losing money. So let's keep working at this. And I know the board has plans for meetings coming up. hospitals have plans for meetings coming up. And the sooner we can see some really important progress that can come back to us, the happier we'll be. And so that's it for today. Thank you all. Really
Thank you.
appreciate